Thank you so much to all of you joining us uh, on the live Zoom session. And as usual, if you have any questions, you're more than welcome to put them on the chat or um, just ask your questions as you need. We're joined by two special guests. My daughter and my son are just having a look at us doing the presentation. So if you hear some questions coming from the side, it might be them. But in any case, okay, no, they both cross with me. Okay, all right. So in any case, today we're hoping to have a talk about this ECG. And so we've got an 86-year-old woman complains of generalized weakness. So, I mean, generalized weakness in an 86-year-old is not something unheard of. It's not something that, we would expect too much from. But it is the type of thing where we would try and investigate and see where it's coming from. Is it an electrolyte imbalance? Is it a renal issue? Is it a subclinical infection? And of course, just with generalized weakness, we'd also look at a possible cardiac cause. And that would probably lead you to doing an ECG. Just as a caveat, one of the most common reasons for elderly people, those in the geriatric age range, to present with weakness is subclinical UTIs or asymptomatic UTIs are very common amongst this age group. And they often present with non-specific symptoms, and a lot of them, especially if they're diabetic and hypertensive, do present with cardiac issues that often don't have any sort of overt symptoms as well. So that's why you'd often find in a patient like this, they're quite difficult, especially, when it's a Saturday, 2 in the morning, you're busy with trauma, and, one of these patients comes in, can be very, it can destroy your morale because, it's going to be a few hours of work. But it has to be done, I mean, everybody deserves to be treated correctly. And, that's what we need to have, that's how we need to go about it. So let's have a look at the ECG now and try and go through it step by step and see what do we get. So the first thing that we're going to have a look at is our axis. So let's try and draw it out there. So we've just got our, sorry, let me rather put it as lines. I think it will be easier. There we go. All right. So let's just line it up. It just looks a bit neater that way. So here we've got lead 1, and here we've got lead AVF. So let's have a look at them. So it's just a matter of being thorough. So we're going to go through them one by one. So case of lead 1, we've got a positive deflection. So we know that we either have a normal or a left-sided axis. We don't have an extreme right or a right-sided axis. And then let's draw it out for AVF. And for AVF, we see that we've got a negative deflection, which means that the electrical system is going in the opposite direction to AVF. So if we have a look at that, and we can see where the two lines match. So we've got a left-sided axis in this case. All right, so just put it as a little arrow over there so that we know. So we've got a left-sided axis. So all that a left-sided axis means is either that there's a problem with the right-hand side that's caused it to receive less electrical input, or the left-hand side is pulling more than the right-hand side, which is more likely in this case, which we'll get to in a second. Now, let's look at the rhythm. So this is one of the interesting parts. So let's have a look and see. So here we've got a P wave, which is our first step to analyzing whether we have a normal rhythm or not. So when we do look at the P waves, they generally look normal. There's one or two that are maybe poorly conducted, but the majority of them on the rhythm strip actually look quite normal, right? So relatively normal P waves. Then let's look at the PR interval, and this is where it starts to get interesting. So if we look at this one, for example, where we're starting off, we're getting about 1.5 blocks. So that's very elongated. I mean, that's about 8 mini blocks. So we know the normal is between 2 to 4. So we've got a very elongated PR interval. If we come to the second one, we can see we've got 1. Now we're almost closer to 2. So we're actually starting to get a PR interval that's starting to lengthen. And when we come to the third one, then we've got a PR interval now that's actually going nearly 2 blocks. All right. So we've got this PR interval that's elongating, and then we've got a dropped QRS complex. All right. So if we go to our next PR interval, because that's where we found a problem, let's see if that pattern follows. So here again, we've got about, let's say, 7 to 8 blocks between our P and our R waves. When we come here, we can see we're actually going a little bit over that. So now we're up to about 9. And then when we come here, we see we're getting also again about 5, also about 8 or 9. So it hasn't elongated too much there. And then when we come here, we're getting closer to, I would say, about 9 or 10 again, but not just a bit of elongation, and then a drop over there. So our PR intervals are elongating. Our QRS complexes, we can note, are a little bit wide. So especially this little lag that we've got over here. So this pattern that we see over here is very indicative of a left bundle branch block. And it's also seen very often with patients who may have rhythm disturbances as well. So we've got a left bundle branch block. We've got a PR that is elongating. And if we look at our QRSs, do we have a QRS following every P, which means does the ventricle contract every time that the atrium contracts? And I think the best place to see it is probably here, where you see we have a P wave and then it drops. No? So we've got a heart block. I'm not sure if anybody wants to venture a guess as to which heart block this is. You can in the chat. In the meantime, it's not a problem. But we know that we're dealing with a heart block. And we know we're dealing with a heart block where the atrial conduction is slowly but surely elongating, so it's getting worse. And then after that, it drops, and then it seems to reset as well. So while you're thinking about that, let's go through our rate. So in these cases, it's always best to pick the 2 closest R waves, and then figure it out from there. But normally your machine would figure it out. So we'll just do a general one. So 3, 4, 5. So about 50 to 60 beats per minute, more or less. So not really bradycardic, but almost there. It might explain why she's feeling so weak as well. Then we look at each zone. Now, one of the problems that we see is that when we've got a left bundle branch block, we often see a lot of ST depressions and elevations and things like that, which don't necessarily indicate ischemia. Okay, so what we do in this case is that we use something called Scaboza's criteria. All right, so I'm just going to put it here. We will talk about it again in another one. So it's Dr. Scaboza from Italy. And she actually came up with these criteria to actually determine if there is evidence of an ischemia with the left bundle branch block. So what we would do is that we would look at concordancy and discordancy. So concordancy and discordancy are quite easy. Concordancy basically means that if the QR complex is pointing upwards and your ST segment or your S wave and your T segment are also above. So in this case, if it was above and not below, that would be concordant. In this case, you can see your QRS are mainly above the isoelectric line. So this is a discordant, ST. Let's put it like that, a discordant ST segment. Here you can see it as well. So this is discordant, this is discordant, and that is discordant. Okay. And the one thing to remember about it is concordancy is bad. Okay, that's the easiest way to remember it. Concordancy is bad. So when you see a patient with a left bundle branch block and the ST segments are on the same side, so in other words, let's try and draw it out here just so that everybody can understand what I'm talking about. So in other words, if you have a QRS complex like this, and let's say our ST segment, let's get another color, sorry about that. So let's say we have our QRS complex just there, and then, sorry about that. Just trying to take it out from the line. I'm not sure why it's not letting me. Okay, there we go. All right, so let's say we had something that looks like that. Then that's obviously going to be concordant, and that's quite a problem. whereas here we have discordancy. Now, the opposite could be true as well with the left bundle branch block, where you could have a QRS complex that goes like that, and then the ST is also depressed. But this is also called concordancy. Whereas what we have here with all of them sort of on the opposing sides is discordancy. Okay. Now, in this case, there isn't an infarct because it doesn't fulfill all of Scarbosa's criteria. But Scarbosa's criteria are quite involved, and I don't want to get into it right now because that's going to turn into a lecture on its own. Okay. All right. So I see nobody in the chat's really come up with an answer as to what this could possibly be. My apologies, the audio is a bit bad. I'm not sure if there's a problem with my speaker, but anyway, yeah. So what we have here is we have a rhythm disturbance now, and we know that we've got a heart block. So there's four basic heart blocks. We've got first degree heart block, second degree, and third degree. And second degree is divided into two. You have Mobitz type 1 and Mobitz type 2. So when you look at this, I'm not sure if anybody knows this pattern, but when you have a PR that is slowly elongating and then eventually dropping a beat, this is a Mobitz type 1. Okay. If we had to look again at all of the regions that we would look at, like 2, 3, and AVF on the inferior, 1 AVL, V1, V2, V3, V4, V5, V6, we'd have to judge them according to those criteria, Scarbosa's criteria, even AVR. And in this case, when you look at it, it doesn't actually show an infarct. The one thing that is a bit worrying is the amplitude of the wave in AVL, even in lead 1. It's quite high. So, and of course, in leads 3 and AVF, it's quite deep. So this leads us to think that there's left ventricular hypertrophy as well, which might be why we're getting a left-sided axis. Okay. So let's move on and see what we have. So in this case, we do have a sinus rhythm with the second degree AV block type 1 or Mobitz type 1 or Wenckebach block. The rate is about 50, as we had said, and it's a left ventricular hypertrophy. There's also a right bundle branch block. Sorry, I had forgotten to mention that. So this is your right bundle branch block. Now that's a complete right bundle branch block in V1 and V2 because it's elongated. Okay, no, it's quite wide. Okay, so we're going to get into exactly why this is Mobitz type 1 and maybe not Mobitz type 2. We can just quickly read this. So Mobitz type 1 is characterized by regular P waves. Here the atrial rate is approximately 65 beats per minute with progressive prolongation of the PR interval until the P wave fails to conduct to the ventricle. Usually there's also progressive shortening of the RR interval until the P wave is non-conducted. And in this case, the left ventricular hypertrophy is diagnosed on the ECG based on the R wave amplitude in lead AVL, and as we had mentioned in the other leads as well. Now, Mobitz type 1 and Mobitz type 2, I've spoken about it previously in the past. Some of you may have watched the videos before, may remember some of that, but what we're going to do is we're just going to discuss the two types of heart blocks because first degree heart block is very easy to understand. Your PR distance is elongated, whether it be quite wide or not wide, or PR interval, but you don't drop any beats. And with your third degree heart block, there's no relation between the atrial beat and the ventricular beat. Your QRS complexes are always wide, okay? But people often have a problem with Mobitz type 1 and Mobitz type 2. So we're going to try and make a bit of sense of it here, and we'll compare the two to one another. So in this case, we've got Mobitz type 1. So as we had said, it's characterized by progressive prolongation of the PR interval until the QRS is dropped. So the problem is normally at the site of the AV node. So the question is, what is happening? Why are you dropping this beat? So the pathophysiology behind it is that the AV node progressively fatigues with each beat, leading to slower conduction. So what that means is that the AV node is receiving the signal from the atrium, but there's because there's a diseased AV node, it takes longer for it to react to that, and that's why you have the slowing of the conduction until eventually it can't conduct anymore. Okay, so you can have parasympathetic influence due to the vagal tone, which can also lead to a delay in AV nodal conduction. So what happens is after the beat is dropped, the AV node resets. And that's why you start getting the shorter PR interval again. And then eventually it just goes on, and it just elongates and eventually drops as well. And it's usually benign and asymptomatic. However, in our patient, 86-year-old presenting with generalized weakness, if you've excluded other things, so for example, renal function is fine, no subclinical infections, no electrolyte imbalances, and she's got this, then of course it's not benign. This is probably something that's going to progress into a worse block, a type 2 block or even a complete heart block, right? Actually, this was something I didn't know until I was preparing this, that it may be seen in athletes or during sleep. I had no idea about that. So I also learned something this time in terms of Mobitz type 1 when I was researching it for this presentation. And Mobitz type 2. So what's the difference? And we're going to just look at it again. We're going to compare the two to one another. So what happens is the PR interval remains constant before the drop. So what that means is that compared to this one, where the PR interval slowly lengthens, in Mobitz type 2, your PR interval is the same. Now, whether it's elongated or it's within normal, that's not much of a difference. The thing is that it remains constant, and then eventually you get a drop beat like what we have. So that's the difference. And that is the major difference. And that's where, if you can remember that, you'll always remember Mobitz type 1 and Mobitz type 2. Okay. Mobitz type 2. Let's go there. So it's typically below the site of the AV node. So it's either the bundle of His or the Purkinje system. So you've had a disease now that's present in that area. So the SA node will then pass it on to the AV node. And if there's AV nodal disease, you may still get a prolonged PR interval. And if there's no AV nodal disease, you'd have a normal PR interval. And then as the conduction system goes further down, that's where you are seeing the problem. So eventually it goes through the simple, almost the same problem as what we saw in Mobitz type 1, where it will conduct, and then fail to conduct, and then reset, and then try to go again. So the block is usually due to failure of impulse conduction in that system. And unlike Mobitz type 1, there's no progressive delay. The block occurs unpredictably, well, relatively predictably. Okay. Now, the problem with Mobitz type 2 is that there's a high risk of progressing to a complete heart block. And it's quite serious. And most of these patients require some sort of pacing. And this is why it's important to know the difference between Mobitz type 1 and Mobitz type 2. Because if you erroneously diagnose a Mobitz type 2 as a Mobitz type 1, you may not think that it's necessary to push a patient onto the cardiology unit or to the medical unit, and you may not pay as much attention to the patient because they may deteriorate quite rapidly, So let's have a look at the two side to side. So again, if we look at our Mobitz type 1, here we can see, well, let's start it from here. So here we can see our PR interval. It's about, let's say, a full block, more or less, about 5 mini blocks. Here we can see it elongates to about 7, and here we can see it elongates to about almost 8, and then you get a drop. Your QRS complexes in a Mobitz type 1 are always narrow. You will never get a wide complex QRS in a Mobitz type 1. And in Mobitz type 2, so one of the things that I used to hear people saying, even I believed it for a while, was that your PR interval had to be elongated. Now, that's not true. It depends on where the blockage is. So in this example of Mobitz type 2, we can see that there's a normal PR interval, normal PR interval, normal PR interval, and then you get the drop beat that's happening over there. And the same thing happens here again. So that's where the drop occurs. Now, the difference with this is that it can be short and it can be elongated depending on whether the AV node is involved as well. And in Mobitz type 2, you may also get wide QRS complexes. So I'm just going to try and draw it to the best of my ability. So another type of, let's make this a bit thicker, sorry about that. It's quite thin. It might be difficult to see. So let's try and draw it out. So an alternate that you may get, for example, is you may get a P wave, and then an elongation, and then you get a wide QRS complex, and then your T, And then again, you would get a wide QRS complex, but it would be more or less the same. Sorry, your PR interval again is elongated, but these two distances would be the same, and it would continue in this vein. All right. So that's another potential of what a Mobitz type 2 looks like. And for those of you who are going to maybe at some point write your ACLS or go further in medical and cardiac studies, Mobitz type 1 and Mobitz type 2 is a very, very common question. It's something that gives people an idea of whether you know what you're talking about or if you understand the conduction system. So it's a good thing to know about. I will tell you, I've sat for the ACLS exams a few times, and they always give, either Mobitz type 1 versus Mobitz type 2 or Mobitz type 1 versus complete heart block. And they're quite generous in that when they talk about Mobitz type 2, they normally give the example that I had drawn out, which is a wide PR interval with a wide QRS complex. And then they give you a Mobitz type 1 as a narrow. And the exam seems to prefer that as a question. So just something to remember. It's not to say it's necessarily like that, but if you see a wide QRS complex, chances are it's going to be Mobitz type 2, especially if there's a prolonged PR interval. Okay. So if we had to put it into a table, this is how we would compare the two. So this is based solely on rhythm strip. So type 1, your P waves are normal, and in type 2, your P waves are normal as well. In your type 1, your PR interval gets longer until the beat drops. And in type 2, your PR interval remains unchanged until the beat is dropped. So that's the major difference. That's why I've just highlighted it in bold over there. And if you can remember this, you'll never have a problem in recognizing the two. In type 1, your QRS complexes are generally narrow, but in type 2, it can be narrow or wide. And of course, your QRS doesn't follow every P. In other words, your ventricle doesn't always beat after the atrium because there is a drop beat, so it can never be, consistent as far as that goes. And your rhythm is generally regular, irregular. Okay, so that's the way to distinguish Mobitz type 1 from Mobitz type 2. So going back to our patient here, because she's 86 years old, she's also got a left bundle branch block. She's got a type 1, Mobitz type 1. We would also investigate, even though it doesn't seem obvious, we would suspect that she may have had ischemia in the past, and that's probably what's led to the blockage or the Mobitz type 1 block at the moment. So it's something that you would keep an eye out for. You might do your enzymes again just to make sure that your patient is not having anything acute, although technically speaking, they shouldn't be, but it's something that you would consider. And it's the type of patient, because of the age, 86 years old, a very high chance that she will progress rapidly to a Mobitz type 2 and then eventually onto a third-degree heart block or full complete heart. Okay. So that's just a little joke to end off. I'm not sure if anybody has any questions or anything that they would like to ask. You can ask on the chat, or if you'd like to ask just via the audio, that's not a problem as well. Let's go back to that ECG so that you guys can have a look at it and see, or if there's any other questions that you may have. Let's maybe leave it there. I'll give you a chance on the chat just for about a minute or so. It's an interesting ECG. Rhythm disturbances and rate disturbances actually account for, I would say, the majority of the problems that we see, in cardiac, when patients are having cardiac issues, but they're also some of the most commonly missed, and they're also some that are the most commonly misdiagnosed. And the good part is that if you are learning about the rhythm or you're analyzing the rhythm just according to these 5 criteria, you'd actually you find that you pick up most of the diseases, because most of the diseases related to rhythm actually just have a combination of 1 or 2 or 3 of these, with one that's unchanged or one that isn't unchanged, things like that. So it's a good practice to always make sure that you read your rhythm strip. If everybody is okay and everybody's happy with the presentation, I want to thank you all very much. I really do appreciate you guys taking your time out and joining me for this. And because we had missed one presentation last year and try and have one on Friday again. I invite you all to join as well. And thank you as well, Dr. Mabuza. I really appreciate it. And yeah, I'll have this up on the uh, I'll have this up on YouTube in a little while. So if you always want to revise it, you can. But thank you so much, everybody. And thank you so much, Wadia, as well. I appreciate that. And all of you have a great evening. And thank you so much for spending your time with me and learning a little bit. And I hope it will help you in the future. Okay, keep well. Bye.